I just want to thank the organizing committee and send my best to everyone, and in particular, Professor Bismuth. I wish I was there with you to share your companionship, and also I'm Polish, so I was hoping that I can come visit my native land in Poland, but hopefully that'll happen in a future date. I was going to talk a little bit today about intrahepatic cholangiocarcinoma. It's a topic that has been near and dear to me and my research group for the past about 15 years. I'm going to go over some of the different practice guidelines that I had the benefit of participating in with ILCA a number of years ago. So we all know that there's significant geographic variation with the incidence of intrahepatic cholangiocarcinoma, with the incidence being particularly high in Asian countries. But even in Western countries, the incidence of intrahepatic cholangiocarcinoma is on the rise. And we typically think of perihilar being the most common cholangiocarcinoma, but clearly intrahepatic cholangiocarcinoma is being seen more and more common in my clinic, and I'm sure many of your clinics. And this is probably due to some reclassification bias, that hepatopathologists are more comfortable now classifying primary adenocarcinoma in the liver as intrahepatic cholangiocarcinoma. But there's clearly some epidemiologic factors in the East, hepatobiliary flukes, PSC, choledochal cysts, and then in the United States, probably obesity and diabetes that lead to oxidative stress and can induce intrahepatic cholangiocarcinoma. As we know, it already is a strong risk factor for hepatocellular carcinoma. And in fact, many of my patients are individuals who are obese, who have a lesion in their liver that is subsequently found to be intrahepatic cholangiocarcinoma. So there's been significant growth in the understanding of the molecular pathogenesis of this disease. There's several different molecular pathways that are involved, whether it be KRAS, TP53, FGFR, or IDH1. And a number of years ago, we looked at our international data set of resected intrahepatic cholangiocarcinoma and did a mutational genetic analysis. And not surprisingly, you can see here that the most common genetic mutations were in KRAS and BRAF, which you see in many GI tumors like colorectal. We just heard that from Dr. Bote. But also you can see in intrahepatic cholangiocarcinoma, the high incidence of mutation in IDH1 and IDH2 at about 20%. And this is interesting when it comes to cholangiocarcinoma because there is a distinct genetic mutational pattern when we look at perihilar and gallbladder cancer, which have a much higher incidence of TP53 and KRAS mutation, compared to intrahepatic cholangiocarcinoma, which has more of a predominance of an IDH1 or IDH2 mutation. And this is important because mutations in these genes can have prognostic importance. You can see here that patients who have KRAS or BRAF mutation in the intrahepatic cholangiocarcinoma can have a median survival of less than 2 years. And if you look at IDH1, there's been a lot of work on this specific mutation in classifying patients into specific molecular profiles. And when I was at Hopkins, we published a paper in Nature Genetics that showed that patients who do indeed have an IDH1 mutation have a significantly worse prognosis compared to those who are wild type. And as many of you know, IDH1 is not only prognostic, but it also is targetable now through specific targeted agents. While much more uncommon, there is a subset of patients who have microsatellite instability with intrahepatic cholangiocarcinoma and may be candidates for microsatellite, maybe candidates for immunotherapy based on their microsatellite instability. So at our center, we routinely obtain a molecular genetic analysis on all of our patients looking for, MSI, FGFR mutation, IDH mutation, and then we'll use that information to tailor the therapy for our patients. With regard to the clinical diagnosis of this disease, well, obviously, unlike distal or hilar, these patients frequently present with asymptomatic disease with a large mass in their liver, which will frequently be biopsied. And it typically can be difficult to figure out whether this is a primary intrahepatic cholangiocarcinoma or a secondary lesion. Hepatopathologists will typically look for biliary dysplasia. And then a good hepatopathologist based on IHC analysis will be able to rule out other primary tumors such as lung, pancreas, and be pretty sure in giving you a diagnosis of a high likelihood that this comes from a hepatobiliary origin. The tumor markers for this disease are very specific, but not very sensitive. And there definitely is a subset of patients who can have advanced disease and still have normal tumor markers. So I typically make sure that patients don't have an undiagnosed primary. I've definitely seen patients who were referred to me for intrahepatic cholangiocarcinoma who ended up having a gastric cancer or colon cancer. So I typically obtain lower endoscopy and then more selectively use upper endoscopy. But the real workhorse is cross-sectional imaging. And it's important to know that there's different radiographic morphologic subtypes of intrahepatic cholangiocarcinoma. The one that we're most common with is the mass forming, which typically presents as a homogeneous, low attenuating mass in the liver that can be characterized with a capsular retraction and tumoral rim enhancement. And then more uncommonly, one would see a periductal or the intraductal growth patterns for intrahepatic cholangiocarcinoma. And based on data for the liver cancer study group of Japan, as I noted, the overwhelming majority of patients who have intrahepatic cholangiocarcinoma have a mass-forming lesion. A good liver radiologist can pretty easily distinguish a large intrahepatic cholangiocarcinoma from a hepatocellular lesion. We all know that HCC typically has early enhancement and late washout. Intrahepatic cholangiocarcinoma typically has the opposite appearance, where on earlier phases it tends to be a low attenuating lesion, and then only on later phases does it enhance. You can see here this CT image, and then usually at our institution at Ohio State, we use a lot of MRI. And here's a kind of sine qua non classic MRI of a patient with an intrahepatic cholangiocarcinoma. You can see a hypoattenuating lesion with capsular retraction. You see a peripheral enhancement with central necrosis. And then you can see some peritumoral ductal dilatation around the lesion. I tend to use PET with these patients. Frequently, PET will show FDG avid disease outside the liver in up to 20 to 30% of patients. And in my practice, if I see positive lymph nodes that are lighting up in the perihilar area or definitely in the periaortic area, then I will not treat these patients with upfront surgery. I would treat them with neoadjuvant chemotherapy. So I tend to get PET fairly frequently in these patients, especially if they present with advanced disease or very high CA19-9. Well, what about the surgical resection for these diseases? About 15 years ago, we put together an intrahepatic cholangiocarcinoma study group, and now we have over 1,000 patients in this group. These lesions can be very challenging to resect. This is a patient of mine. You can see a large lesion in the central aspect of the liver that's in segment 4B, but also 5, and it's including the anterior sectoral branch of the portal vein. And then, these patients can need an extensive operation, in this case, an extended right hemihepatectomy. But because of sometimes their size and their location, you can see that obtaining a wide negative margin can indeed be challenging. So we've looked at this and published on this. Obviously there's a lot of interest in anatomic versus non-anatomic resection around hepatocellular carcinoma. So we looked at this for intrahepatic cholangiocarcinoma. At least based on our data, there are no differences in either disease-free or overall survival when it comes to anatomic versus non-anatomic resection. But perhaps not surprisingly, what is important is obtaining a negative margin. And you can see here that both disease-specific survival and intrahepatic recurrence, as well as overall survival, was strongly correlated with one's ability to achieve a negative margin. And in particular, you can see here that overall survival was indeed better when the negative margin was at least 10 millimeters. Sometimes in order to obtain a negative margin, one needs to do a vascular resection, either of the caval or the reconstruction of the portal vein. And you can see here from these data that doing a vascular resection in order to obtain a negative margin has no impact in long-term survival, but can be associated with increased perioperative morbidity and mortality, and therefore should be done in only in centers of excellence. Well, what about surgical staging or pathologic staging of this disease? This has been a long-term interest of mine. As many of you know, there was no staging for intrahepatic cholangiocarcinoma up until the 7th edition of the AJCC staging manual. Until that point, intrahepatic cholangiocarcinoma was staged the exact same as hepatocellular carcinoma, which intuitively made no sense because these are two different diseases. There had been two Japanese groups that proposed a staging for intrahepatic cholangiocarcinoma, but these staging systems performed poorly when attempted to be validated in a Western series. So now, over 10 years ago, our group proposed a simplified staging system for intrahepatic cholangiocarcinoma based on number of lesions and also the presence or absence of vascular invasion. And this was actually adopted into the 7th edition manual of the AJCC UICC staging system for intrahepatic cholangiocarcinoma. And this was recently updated in the 8th edition. And as you can see now, T1 disease is based on tumor size cutoff of 5 centimeters. T2 is based on the presence of vascular invasion and whether the disease is multifocal or unifocal. And this staging system has been validated by our group and others and has been shown to be prognostically relevant and robust. More recently, our group has looked at the concept of tumor burden score. And this is a single composite score that assesses the entire tumor burden in the liver, that looks at the number of lesions as well as the size of those lesions to come up with a single composite score. And our group has shown that the tumor burden score is a very powerful predictor of both overall and disease-free survival. And in fact, those patients who have a high tumor burden score have a 5-year survival of only about 7%. More recently, we've used machine learning to identify different groups or clusters of intrahepatic cholangiocarcinoma. And using machine learning, we've identified what we have called the common ICC, the proliferative ICC, and the inflammatory ICC. And you can see here that using artificial intelligence to subsegment out different groups of patients, we've identified an inflammatory ICC group that does significantly worse with a 3-year survival of only about 13 months. What about lymph nodes? This is a kind of a hot topic about whether one should do a lymphadenectomy for intrahepatic cholangiocarcinoma. And if you look at our series, even at major centers, lymphadenectomy is still only done about 50% of the time, even though the incidence of lymph node disease is anywhere from about 18 to 30%. Our group and others have tried to predict whether someone will have lymph node metastases preoperatively using different type of algorithms and prediction tools. But in general, it is very difficult to predict this preoperatively. And that's why we recommend routine lymphadenectomy at the time of surgery, because lymph node status has important prognostic information. And we do it for colorectal cancer, we do it for gastric cancer, we do it for pancreatic cancer. And if you do not have the lymph node status, then you cannot stage the patient, because you can see here that both the presence or absence of vascular invasion and whether the tumor is single or multiple is no longer prognostically important once the patient has metastases to the nodal basin. Therefore, one should perform a lymphadenectomy at the time of surgery, and the extent of that lymphadenectomy should be dictated in part by where the tumor is located, as again identified by the Liver Cancer Study Group of Japan. Currently, it is recommended that you get 6 lymph nodes at the time of surgery. However, as you can see here from these data, it is very uncommon for us to get 6 lymph nodes at the time of surgery. And you can see that only about 15% of the time are we recording 6 lymph nodes in the pathologic specimen. And again, if you look at national data from the United States, only about 50% of the time are we even getting 1 lymph node. So finally, if we think about why is all this important, it's because this is a disease that has a very significant and poor prognosis. If you look at cure models, we are only curing about 10% of patients at 10 years. And the reason for this is that recurrence is ubiquitous. If you look at the incidence of recurrence, over half of patients will recur in less than 2 years after their operation, and half of the recurrences will be outside the liver. So not too dissimilar to pancreatic cancer. This is a systemic disease at the time of presentation for many patients. And we recently published a paper in JAMA Surgery showing that even up to 1 in 5 patients may recur in 6 months after surgery. So we have published a calculator trying to identify those patients who are at the very highest risk of early recurrence. And we would advocate that patients who have a very early recurrence risk based on our calculator or based on the fact that they have multiple lesions and or that they have lymph node metastases, that these patients should be treated with neoadjuvant therapy upfront to better define their biology so we can better select patients for surgery. And then finally, as many of you know, there have been several adjuvant trials lately with regards to biliary tract cancers, both the BILCAP and the Protégé 12. The Protégé 12, looking at GEMOX, was a negative trial that showed no benefit to adjuvant therapy, while BILCAP showed a roughly 25% improvement in overall survival using capecitabine. And so for most people in the United States, we would treat patients with adjuvant capecitabine. It's also interesting to note that in the Protégé 12 trial, where there was no benefit, there were significantly fewer patients who had nodal metastases and significantly fewer patients who had R1 disease, again suggesting that in high-risk patients in particular, some type of adjuvant systemic therapy may benefit them. So in conclusion, our data over the last 10 to 15 years has looked at intrahepatic cholangiocarcinoma. And I think what we've demonstrated and what we all know is that this is a significant disease with a high case fatality, and that only with better systemic therapy and targeted therapy, similar to what has been achieved in colorectal cancer, we'll be able to achieve better long-term outcomes for our patients with this disease. So again, I'd like to thank you for the opportunity to present, and I very much look forward to being with you in person next year. Thank you.